So today, a little bit about diabetic foot checks. How do I do this now? Yes, here we go. There we go. What are diabetic foot checks? Well, first of all, these are routine assessments that we should be carrying out for anybody with diabetes, not just the elderly, anybody who is diagnosed as diabetic, because it helps identify any early signs of problems that may be occurring in the foot due to poor circulation, neuropathy, pressure damage, skin breakdown, infection, ulcers, a variety of things that can cause the damage. This is a preventative activity on the whole, because we want to try and identify any problems in people's feet before they become a problem. So looking for early signs of changes to the structure and the skin and sensation before they become an ongoing problem. Why are they essential? Loss of the sensation in your feet means that people who have diabetes might not notice that they have pain or they have pressure or heat or any trauma due to their feet, due to the peripheral neuropathy that may be happening within their feet due to their diabetes. Injuries, therefore, may go unnoticed, and recovery can be slower. Even small problems can easily bloom into something bigger if they're not caught early and treated appropriately, which is why early intervention and timely referral and clear documentation is paramount to what we do. We all know about documentation and how essential it is to make sure that what we do is documented well. So I've got you a 5-point checklist to have a little look at. Symptoms that we would be looking for on a diabetic foot check would be any pain, any numbness, tingling, burning, altered sensations. I don't know what onset, I think I'm missing a word there somewhere. And any new patterns of problems within the foot. You're going to need to look at the person's skin, look for any cuts, any blisters, whether there's any ulcers maybe showing or any early signs of ulcers. If there's any discharge, especially around nail beds or any sores on the foot. Any changes in colour or any signs of infection or delayed healing that may be present in the foot. We talk about history, so it's always helpful to know if the person has previously had any problems. And I know sometimes with the people that we care for predominantly, as there is cognitive impairment, we may not be able to get an accurate history from them, but we need to make sure that we exhaust whatever avenues we have to try and get an accurate background on the person and their foot health. We need to look at the vascular supply to the foot. So we need to be checking for any claudication, which is discoloration, or I can't think of the word, when capillary refill. We need to be monitoring the person if they are walking. Are they walking differently? Is there any change in their gait, which may be related to any pains or any problems that may be causing in the foot? It could be a sign of altered sensation in the foot, but that could be a good way of spotting it with somebody. We also need to look at people's footwear. This is important. We have a lady here at the moment who has a sore on her foot because she has some lovely new slippers. However, the seam on the slippers goes right across the front of her toes, and that's caused a problem. So we need to be aware of the type of footwear that the person is wearing, whether it's well-fitting, whether it's causing any problems. We know that the elderly especially can have misshapen feet due to bunions and corns and people's age generally, and standard footwear may not be the best footwear for this person. So what do we have to do if we're going to do a physical foot check on someone? We need to look at the skin and the nails, see how it feels, how it looks. You want to look at the surface of the skin, including between toes, for breaks, fissures, any maceration, which is excessive moisture within the skin, any calluses or corns, any notable redness, if there's any swelling or ulceration or signs of infection present. We need to look at people's nails, check for thickened nails, ingrowing nails, any trauma or fungal changes that could increase pressure or break skin. Because once you get a break to the skin, when somebody has peripheral neuropathy and poor blood supply and circulation to their feet, it can reduce the healing that is going to take place. We need to look at shape and circulation of the foot. So any deformities, as I mentioned, look for bunions, any clawed toes, prominent metatarsal heads. It's a nice word. Charcot related changes, any structural problems, or any points of pressure that may be notable. Look at the circulation. We need to make sure that we're feeling pulses, whether it's on the top of the foot and the back of the foot, to make sure that there is a good blood supply that's there. If you do have a concern, that would need to be escalated and get that assessed properly. Feel the feet, have a good feel of them, make sure that they're not cold when they shouldn't be cold. Look for different changes in temperature. Look for any signs of really poor capillary refill, and make sure that you're comparing both feet together, because comparing the feet will give you a good indication of whether this is something that's happening both feet or just the one. Sensation testing. So everything that I found out says that we should be using a 10 gauge monofilament to test for sensation, but I don't know whether we would be doing that in a care home. I know I've had that done when I've had my diabetic foot checks done at GP surgery, but it's not something we would generally do, or vibration testing. But we can look and try and assess for any changes to sensation in the feet as we're doing these checks. And then again, review footwear, because the footwear needs to be suitable, well-fitting, because poorly fitting shoes can directly contribute to any skin damage and the development of ulcers on the feet. So risk stratification and referral. I've put a little table together just to summarize different risk categories, typical features, and referral and monitoring actions. So if we have something that is just a low risk with minimal clinical features, we would just need to document that, explain what we're finding, and then document what we're going to do to make sure we're monitoring this and eliminate any causes if we're able to. Anything that is a moderate risk, we would need to make sure, we record it and identify any current risk factors, clearly explain what it means to the person, and refer and monitor it accordingly through the local foot protection pathway. I don't know how it works in England. In Wales, especially in Devon, our health board, we have a lower limb service that we can refer to if we have concerns. But I don't know if that's, I'm sure you have an equivalent in your areas. Any high risk issues that you identify needs to be escalated quickly, and ensure that a timely referral is made, and specialist foot services need to be aware so that they can support and offer any suggestions and care planning that they're able to add in whatever we have. And if there's any massively active foot problems, then definite urgent referrals are imperative. Go through the multidisciplinary teams, GP, diabetic foot team. We have a nurse that comes in who's a diabetic specialist nurse. She is great at supporting with anything that we need as well, and she can support with escalating and pushing referrals through to the lower limb service, which they're good on their own, but she can be an additional resource. So This is just a small table just to show some of the milder issues progressing through to urgent referrals on what should be done. Happy to share the slides with anybody afterwards if people wanted to have a look at this. So, key practice points for staff. Essentially, the first thing we want to do is promote any prevention plans that we possibly can, try and minimize any chance of external forces causing problems with people's feet to begin with, because as we all know, prevention is definitely the best thing that we can do. Always use a structured approach when you're doing diabetic foot checks. Make sure that you're touching the foot, feeling the foot, using a mirror to look underneath the bottom of the foot if you're not able to raise it, because obviously not everybody's able to raise feet to a level that you'd be able to view easily. Make sure that you escalate any issues that you find, and follow local pathways to ensure that timely referrals and communication with podiatry, diabetes teams, and any other urgent care services that you have are made. And paramount important is clearly document everything that you do. Make sure that once you've done your diabetic foot check that you're documenting that, one, that it's been done, two, any problems that you found, or if you don't find any problems, make sure that's documented as well, because that can have a history, can show up in a history of a person to show that to this point there's been no problems. However, from this date onwards, we've started to see that there are issues. So that can give you a good picture of how changes have happened within a person's foot. And then I put together some references of where I've taken some of my information from for you. Don't know if that's any good for you. That's generally what I have.
Thank you so much, Mike. That's really great. And thank you for doing that and talking through it so eloquently through it. You've got some claps at the bottom there. Yeah, has anybody got questions? Please do just unmute yourself, or observations, things you'd like to share about foot checks that you've undertaken, or challenges where maybe things haven't been noticed straight away and the problems that can cause.
While people are thinking of a question for you, Mike, I'd just like to say that that was really great. I've got some nodding of people in the background who are listening on a different device, but on my camera. So I think what's also important, which you alluded to there, it's about how you communicate what you find. I mean, obviously, you know, every company, every home have slightly different ways of recording it, but it's the recording and the communication of that to the other professionals that are involved that's really important. So to raise awareness of this amongst people who may not actually carry out the foot check for a dedicated reason or feedback, but it could be just internal practice within homes to be very aware of people who have diabetes or who are prone to issues with their feet. So I think it's great to raise awareness of that.
One thing that we have within our group is a learning pathway for staff to be able to do diabetic foot checks, because you think, well, it's a simple thing, check somebody's feet, but it's not that simple. Yes, check somebody's feet, that's great, and if you see something, highlight it. However, if you're doing a diabetic foot check, you need to know what you're looking for, what to identify, and how to escalate it. So we have a form that we use where we will work through with somebody. We will do 3 diabetic foot checks with a person, and make sure that they are comfortable in and competent to do a thorough job to make sure that we're identifying any issues appropriately.
That's brilliant. And how quickly do you sometimes see problems developing, Mike, when they're not, you know, if the diabetic foot check hasn't been undertaken regularly? How fast do you see breakdown?
you can see a change within a day very, very often, especially something related to pressure. Pressure change and pressure damage can show up so quickly. It doesn't take long for something that would be causing pressure on somebody's foot to cause an issue. And then if somebody does have peripheral neuropathy and poor circulation to their feet, the chances then that that is going to develop into something more significant is a lot higher. And that's where your problems become an issue.
And I'm guessing you mentioned about the fact that the cohort of people that we're working with obviously have quite often some cognitive challenges.
Yeah.
I'm wondering if they're having the diabetic foot checks more regularly, does it make them more accepting? And also I'm thinking about, like the lady you were saying who's got her lovely new slippers, but it's actually the seam is aggravating her feet. So obviously you need that acceptance from the resident as well as from all your staff being aware why those slippers shouldn't be worn for a while. Presumably you're sort of putting them out of sight for a little while for that family member.
I think it definitely varies by the person. The lady that I was referring to, she doesn't have, she has very minimal cognitive ability. So the slippers have been removed. It was discussed with the family. They apologized that they didn't even think of this when they brought them in and gave them to her, and have instantly said they'll replace them with something more appropriate. But it depends on the person. If somebody has just a mild cognitive impairment, and as long as you're explaining what you're doing and communicating with the person and getting them involved and asking them to give you feedback as such, as you're doing things, you're likely to get a better response from them. Obviously, not everybody has the cognitive ability to be able to take part and help you and answer questions appropriately, which is where we use our expertise and our experience of working with people who have significant cognitive impairments